good afternoon, everybody, and welcome to PQA's February Quality Forum. We're really excited for today's presentation. It's all about interoperability and quality, and we're joined by Josh Howland of PioneerRx. Similar to all of our traditional logistics that we see, send us your questions. So use the GoToWebinar control panel, type in your questions, and let us see them so that way we can answer them. Today's forum is being recorded, and a copy of the slides and audio will be available within PQA's member portal on the website, and then give us your feedback. So when you close out of today's webinar, there'll be a quick survey to ask about feedback. Just as a heads up, our next quality forum is going to be scheduled on Thursday, March 12th. We are going to be doing antimicrobial stewardship, opportunities to optimize antimicrobial use and improve quality with Luke Schultz. So today's presenter is Josh Howland. He's a PharmD MBA. He's the Vice President of Clinical Strategy for PioneerRx. In a couple slides, when I hand it off to him, he's going to be able to give a deeper dive in his bio. And so what I thought I'd do today is kind of provide a little additional context for why we are here and why we're talking about interoperability and quality. So last November at PQA's Leadership Summit, we took a deep dive in 4 national health priorities, one of which was interoperability and quality. And during our Leadership Summit, we did more of a active, engaged type learning. And through that process, we had small groups. And Josh was one of the members of the Interoperability and Quality Small Group. And throughout the conference, all of the feedback I kept hearing was, we're not quite sure what interoperability is, but Josh keeps teaching us so we understand it. And so one of our major takeaways from the meeting was to get Josh to share this story and this information with the larger PQA audience. So we're really excited for him to join us. The other thing that I'd like to point out in regards to today's webinar, different from some of our other presentations, is Josh and I talked about this, and we would love your questions during the presentation. So as you have thoughts, as you have questions, if you are getting lost in the alphabet soup that is interoperability, please send us the questions, and we're going to make this more of an interactive webinar just because we recognize it's a little bit more technical and wordy, and so we want to be able to kind of interspice the conversation with your questions. So again, as you have questions, we're going to be interjecting them throughout today's presentation, but we do have dedicated time at the end for our Q&A. And as always, we like to end our quality forums 5 minutes to the hour to give us time to transition to our next meeting. And so without further ado, Josh?
Great. Go ahead and stop off to the next slide and we'll get started. So as mentioned, my name is Josh Howland. I'm the Vice President of Clinical Strategy at Pioneer. That means today, although I am a pharmacist, I spend a majority of my time working to understand what pharmacists are doing, what they should be doing, and then building and designing features in our software that help them do that more efficiently. As mentioned on here, I'm a pharmacist by training. I like to joke that I liked Austin so much in undergrad, I decided to stay another 4 years and do a PharmD. And then liked the University of Texas so much that I did my MBA there through the Dallas Co-op. Really focused on healthcare reform and quality and process improvement. So throughout my career, went from bench pharmacist to PBM, and then spent a few years in renal specialty pharmacy, really figuring out how integrated care should work or could work. And then decided to really kind of put that on a higher level because we kept finding a lot of places where data didn't match up, software didn't exist, being able to share information from pharmacists to nephrologists to dialysis center, all of those things that sound like they still happen today, and why I'm interested in interoperability and quality. Next slide. So the things we're going to try and cover today, and it's weird to start a presentation with a disclaimer, but it's really important here. So you're going to see a lot of content. I threw in a lot of buzzwords that you're going to hear in, different conferences, different email blasts that come through, all of your various groups. So the goal here today is provide a really topical overview of healthcare interoperability, give you a small understanding of why it's so important if you haven't already discovered that being able to share information is vital to the next generation of what healthcare can be. give you a quick, very quick and slim overview of standardized healthcare terminology. This will be barely scratching the surface of a 30,000-foot view. Remember, people dedicate their entire careers to just this one bullet point on objective number 3. Kind of give you a quick overview of where we are and where we're going with the Pharmacist eCare plan, and then understand the capabilities of sharing that data once you've got it all together. Okay, next slide. So where do we start? You know, Lewis Carroll, I think, said it best. Begin at the beginning, the king said very gravely, and go on until you come to the end, then stop. So right now, I like the idea behind this because it really, this is the rabbit hole, right? We're about to find out how deep the rabbit hole goes, and we're going to start at the beginning. So next slide. So in starting with why, it's always important to understand why you're going to do something. You know, start thinking about those questions of why interoperability standards are really important. I can check my bank balance literally anywhere in the world, but I can't do the same thing with my health records. That seems like it's weird. Why does a web page look exactly the same regardless of my geographic region, the type of web browser I use, and to an extent, whether I'm using a computer, a tablet, or a telephone? And then, you know, why can I get email in near real time? And true story about this x-ray, a couple of years ago, I tore a rotator cuff muscle in my shoulder, and I initially went to my doctor, who referred me to an orthopedist. I literally had to physically check out my x-rays from my doctor's office and carry them with me to my specialist office in the same building, right? Those are because we don't have good interoperability standards in practice yet today in healthcare. So I can check my bank and view web pages because they all use the same language to talk to each other. And that's where we're going with healthcare. So next slide. So we're going to start with the simplest, the smallest concept here, data, right? We always talk about there's just this plethora of data across the planet. But at its core, data is just information, right? It's going to give you some kind of reference or a way to analyze it. We have data everywhere, but until you can do something with it, that's interpret, analyze, make a graph, all of that data is just kind of useless, right? And we have literally millions of data points across healthcare, but because nobody can translate it, collate it, and do stuff with it, it's essentially useless. There's also a concept of structured data and free text. SOAP notes are a great example. Today, they're almost entirely free text. It makes them all but impossible to do anything meaningful with in terms of analyze for quality, to look for content that's there, more importantly, to look for content that's not there. So we're trying to move a lot of the data into structured data elements, and that means the interoperability languages that we're going to kind of go through. But when you really think of data, think of it like it's a DNA strand. Data is the ATCG of that data, or of the DNA. Together, on their own, they don't really mean a lot, but when they're structured and translated into that double helix, then you get things as amazing as humans. Next slide. So why do we really care about interoperability? Aside from the concept of being able to check your email and view web pages anywhere in the world, interoperability allows for a level of efficiency that just doesn't exist in the United States healthcare system. So interoperability will, in theory, allow for seamless and a near real-time transfer of useful information. If I, for example, fill an opioid at my local pharmacy and then drive across town to a different chain and try and fill another one, interoperability allows that first fill of the prescription to be reported and used, and so that second pharmacy could prevent fraud, waste, and abuse. They could help with prevention of addiction. So all of those things just kind of compound when you can transfer information very, very quickly. Another one is kind of a concept in manufacturing, and it's called the bullwhip effect. So what happens with manufacturing is you have a bunch of different actors across a logistics stream, and say the manufacturer starts, he builds some product, hands it off to a wholesaler, the wholesaler hands it off to a store, and in the middle of that, the wholesaler accidentally doubles the order, and then the manufacturer thinks they've got a huge amount of demand, so they ramp up their manufacturing capabilities and they create a whole lot of supply, but it was an order error, and so by the time it gets corrected, you've got the whole logistics chain out of whack, and that's exactly what happens here. If healthcare is very, very sensitive to those types of changes, so this interoperability allows for communication between pharmacist, prescriber, nurse practitioner, occupational therapist, all of those people that play roles in making sure that patients are cared for. Even as social determinants of health come on board as being like a real focus, being able to communicate back and forth that, hey, this patient didn't get this medication because they had to choose this week between eating and buying their medication. All of these things improve with being able to share that information. So better coordination, better safety, stronger privacy and security. All of those things just get better and more profound with more robust interoperability standards. So next slide. I'm not going to spend a ton of time going through the academic evaluation of interoperability, but interoperability really just means the ability of different information systems to send, consume, and exchange data. There are a couple of types you'll occasionally hear about, foundational, structural, and semantic. But at its core, there's kind of phased approaches of interoperability. Can I send a file from me to you? Can you receive that file that I sent you and do something with it? And then can I use a common language to use that information, right? So at its highest level, you're looking for semantic levels of interoperability. That's the holy grail. It's why the internet's amazing. My web browser always goes to the same place. It always speaks the same language, and anybody can use it. Next slide. So now we're starting to think about standards and terminology. This is just the kind of menu of buzzwords that you will hear about, have heard about, and if you haven't heard about them yet, you will soon. So kind of breaking them down into things that you need to know about. A lot of interoperability around healthcare is HL7, right? So that's Health Level 7. It's a standard development organization. All of these things, including FHIR and CCDA, which we've got both here, really are around HL7 transfers. And the big kind of misnomer I always hear people say, well, do you have an HL7 capability? And everybody says yes. So the assumption there is that, great, we're interoperable now. That's definitively not true, right? So there's kind of a joke in healthcare that if you have one HL7 feed, you have one HL7 feed. So it uses a standard, but the feeds aren't all the same, right? So we have to start thinking about different levels of those types of things. So within HL7, you kind of have these content standards, and it's clinical document architecture. There's really a lot of transferring information within an electronic health record. So between inter-hospital groups, those are done through clinical document architecture or CCDA type format. Then you have people and groups that care about making sure that all of the terminology is managed, grouped, and aggregated appropriately. For pharmacy, that would be the pharmacy HIT group. And there's some resource links at the end of the presentation to kind of, you can go look at those. But the pharmacy HIT group really looks at making sure value sets, and that's coming up next, are cared for and maintained. And those value sets contain different structured vocabularies. So that's where you get your SNOMED, your ICD10s, your RX norms, and your LOINCs. And there's a little bit more detail for each of those coming up later. In the transport standard, that's where kind of the new pharmacy eCare plans live. That's called FHIR, or Fast Healthcare Interoperability Resources. That gives a very clear way and a new generation approach to the older CCDA format. You can now transfer information via FHIR. It's just a way to transfer information back and forth. The beauty of that is it speaks a common file transfer language. And it also allows for systems to go away from the old way of having to map every single data element to another data element, to using a file that allows for a system to say, I recognize these things, let me consume them. And I don't recognize these others, ignore them. So it means you don't have to constantly update and reconfigure your file every single time that file contains something new. It's a huge, huge piece to interoperability today. The last two, and I'm not going to spend a ton of time on these, are the Office of the National Coordinator, that is commonly referred to as the ONC. That's the government group that really cares about healthcare IT and interoperability. So a lot of think of them as the umbrella group that everybody else working on interoperability is thinking about and using standards and guidance that they provide. The other is Enhanced MTM. It's currently in 6 states piloting to kind of be the next version of MTM. I mention that because they also use structured code sets like SNOMED and ICD10 to transfer data. So at some point in the future, the Pharmacist eCare plan and the Enhanced MTM model will probably use the same architecture and standards to transfer data back and forth. So today they're in the right direction, but not totally there yet. Next slide. All right, so I'm not going to spend a ton of time on ICD10, but it is the most common vocabulary or terminology that I'm sure everybody's here at least heard of or is at least peripherally familiar with. When you see ICD10 codes, you almost universally think this is for medical diagnoses. Specifically, when you say something like, I have type 2 diabetes, you're looking at ICD10 CM for the clinical modification. Those are the diagnostic coding. All of the procedural codes are in inpatient use only. So for the most part, when I say ICD10 codes later in the presentation, I'm referring to ICD10 CM. But think about this as the building block. We got a common way to tell anybody across the healthcare spectrum what diagnosis a patient has. This was essentially the first level of interoperability. Next slide. So the next slide is this is Snomed CT. This is the standardized coding terminology. Again, just like with interoperability levels, they have a whole slew of relational mappings, components, concept codes, descriptions, relationships, and then reference sets. The main takeaway here is that SNOMED codes do a couple of really important things. Most importantly, they tie other code sets together with different things like observations, procedures, and findings. So if you think of the Snomed code as an analogy of the spinal cord. So there's ICD10 codes, there's LOINC codes, there's RX norms, there's NDCs, there's all kinds of other different values, but they all map to a Snomed code. So when we build a document that we can transfer as an interoperable standard, all of those things eventually tie to a Snomed code. So I have an ICD10 code for type 2 diabetes. I have a Snomed CT code for type 2 diabetes. I tie those together, and then once they're all tied together, we're all in the same language. So that Snomed code, think of that's your spinal cord coordinating all of your body's activities. I'm moving my arms and legs. All of that's being done by signals that the body interprets. Snomed CT codes are the way we tie those things together. Next page. And here's where the real value behind Snomed CTs get all tied together. There are hierarchical maps of those Snomed codes. So for example, on this page, the Snomed 127785005 is tied to a common description of administration of substance to produce immunity. And then you can see down below where that hierarchy code relationship comes into play. So immediately above this Snomed code in the hierarchy is the parent, or administration of a drug or medicament. And then the descendant tree will tell you the other things you can do. So when you're structuring that, think of them as your title is, I gave a drug to a patient. The next level down is, I gave the patient a vaccine. The next level down is, I gave the patient a Bordetella vaccine, right? And Snomed nests those nicely so that you can always tell what you've done, who you did it to, was it a procedure, was it a finding? So that's really how it's all set up. It's very, very organized, and it's all based in hierarchy. Next slide. Why that's vitally important is illustrated right here. Language is a masterpiece of human advancement, but we do weird things. When a human says something, they mean the same thing. We understand the context of that phrase, but if you write in a patient's note, vax admin, vaccine administration, administered vaccine, immunized patient, you could probably think of 20 or 30 different ways to write that down. But with interoperability in Snomed, what we do is we take all of those types of ways you could write something and codify it, so that no matter what you write on the left, on the right, when we send that through some type of architecture, FHIR, Pharmacist, eCare plan, it's always mapped back to one thing. That allows the Snomed code, in this case, to be the Rosetta Stone of the infinite ways humans can say or write something and always mean the same thing. Next slide. So now when we get into value sets, and this value set library is linked down at the bottom here. It is administered by the National Institutes of Health. It's free. You can sign up and navigate through and tinker around, and I highly recommend that you do. But at the same time, just understand that a value set is a grouping of these codes that are developed and maintained by a steward. So in this case, I've kind of highlighted here that the pharmacy HIT program, or collaborative, maintains these value sets that are relevant to pharmacies. So they would put in a group of, say, like, these are the encounter reasons. Encounter reasons would be why the pharmacist is talking to the patient that day, why you were seen. And so pharmacy hit will maintain this value set for encounter reasons. The OID here is the way to organize and say this OID relates to this value set, similar to SNOMED. Structural way to relate that these codes go together. And you can see right now there are currently 13 codes that are in that group. So the Value Set Authority Center is a searchable repository of all of these code systems and value sets. So today you can go in there and look for any steward, any value set that Pharmacy Hit maintains. You can go and look for pretty much any SNOMED code, LOINC code, HCPCS, CPT codes. They're all there and they're all maintained to say that, you know, this group cares about these types of things and here's how they're organized. Why that's important is when pharmacy systems or EHRs in general provide you with a drop-down list, say if you're going to say, I want to see this patient today for a comprehensive medication review, you don't want to have 2,000 different vendors trying to give you 2,000 different variations of drop-down lists and things that you can do. So the value set is a way to define what's in those lists that you'll use, and so you get the same lists no matter where you're at. And think about that as a way to make sure that we're all still trying to speak the same language, independent of whether you use, you know, the pharmacy system I work for, Pioneer, or one of the other 20 or so on the market. It's again a similar way to just to say this is a common language. These are the things that relate to this type of activity, in this case encounter. So tying all of this stuff together. Next slide. So when you dig into the value set, kind of get a quick overview of what it is. Again, still based in hierarchy. It'll give you the name, what the code system's based in, who the steward is, any types of other details that you need, and the types, or sorry, the exact codes and descriptions of the things that go in that group. So we're looking at encounter reason. I mentioned that there were 13 of those encounter reasons, and they're listed here. So why you might talk to the patient, counseling about nutrition, doing a general patient education, I administered a vaccine. So all of the things that a pharmacist may interact with a patient for will be here on a high level. Below that, you could say, like I mentioned before with SNOMED, you could give them administration of a drug, administration of a vaccine, or administration of Bordetella. We can all map those back together to, at its highest level, administration of a drug or medicament. Next slide. I guess I'll pause right there since we're moving into another value set. Any questions about SNOMED and value sets, why they are what they are? Don't see anything. Okay. So
yeah, we haven't seen anything come in yet, Josh.
Okay.
I'll add one commentary though, since we kind of opened it up for dialogue a little bit, and say that the value sets are really helpful, and I love that you spent a lot of time on it. We as a measure developer often look at them thinking about harmonization, and so value sets can be almost medical condition based, and so it could be like, how do you define someone that has atherosclerotic cardiovascular disease, for example, and you can find value sets such that it defines it in a standard way, so it can be reproduced within different entities. So there is a lot of utility to these value sets in identifying populations, not just from that interoperable perspective, but from, say, a measurement perspective.
Yeah, I mean, again, this is such a topical overview. There are lots of people with full-time jobs just working in those value sets.
Yep. So because we shot the breeze a little bit, we did get a question if you'd like it.
Oh, perfect.
Yeah. could you describe why a hierarchy is relevant, especially as people often say things like, quote, well, all the data is there, it should be quick for me to get this high-level value?
Sure. So the way that they're mapped to a hierarchy is relevant. If you want to go back one slide. So in this list where we are talking about encounter reasons, if you think about really the top two lists here could be used semi-interchangeably. And this is where humans aren't ever predictable, right? So one place may do their standard to say, every time I give a vaccine, I use Snomed code that's related to administration of substance to produce immunity. Another institution may say, I use the higher level administration of a drug or medicament. The hierarchy there isn't as relevant for the individual user. Well, it is in certain cases, but for the most part, what that allows us to do on a large scale when we're finding out how many vaccines were administered across the United States in October of 2019. The old way of doing that was chart reviews, public health. The interoperable way of doing that is mapping both those two Snomed codes back to their nearest parent. In this case, both of them are related to the parent of administration of drug or medicament. So it gives you the ability to wrap up very, very detailed things into the next highest level. And it also gives you the ability to say within those highest level orders, so administration of drug or medicament, I want to see the detail underneath that. So I could see how that breaks up into how many of those were vaccines, how many of those were long-acting antipsychotic injectables. So think about that as a way to understand what somebody meant when they said one thing. It's one of those fundamental things of anytime you want to be able to report on quality or what happened, you have to be able to speak the same language and mean the same thing. The hierarchy gives you the ability to do that.
Thanks, Josh. Another user commented, it's just like the nomenclature for animals and plants and everything. So it's a way to think about how we all started out as a little cell, and now we are who we are. We are related to other animals.
Yeah, I mean, the genus species kind of nomenclature is very, very similar in understanding, right? Like, in fact, that's probably the best analogy you could think about is value set or coding hierarchy is the same way we name the animal kingdom, right? There's a high level, a next level down, a next level down, and eventually you get down to Josh's pet dog, right?
We did have another question that came in regards to Snomed, if you'd like that now, Josh.
Sure, let's do it.
All right. So this one is a little bit more focused on your organization. So if you want to kind of share what your organization does, and then also maybe you personally, in case you might have like a different role or responsibilities with organizations. But what steps are taken by PioneerRx to promote harmonization of Snomed codes for pharmacy? And do you sanction any particular Snomed value sets?
So we are members of the Pharmacy HIT Collaborative, and we work fairly closely with groups like PQA and CPSN to make sure that we're not going totally off the reservation. But the biggest one there is working with groups like Pharmacy HIT to really ensure that the value sets that we're using are the right ones. If we have, say, a pilot somewhere where there's a Snomed code that's missing, we can work with that group to get those Snomed codes added to the Snomed language and then allocated to the appropriate value set. So this is one of those areas where people who are traditionally competitors are working together as for the interest of healthcare as a whole. So, in that group, you've got all of our direct competitors, us, people from academia. And so it's really, that's the most important group to make sure that Snomed codes and value sets in general are standardized across the ecosystem.
Awesome, thank you. And almost to take it a step forward there and to kind of look at your slide, because this again is something that we've done here at PQA, is when you look at the Value Set Authority Center, in the middle of the screen, you can see where it has a steward contact information. And so to kind of piggyback off of what you were saying, Josh, is if you want harmonization, one way to do that is to contact the stewards for these value sets and kind of work with them. So that way there is that gold standard at the VSAC.
Right. All right. So I'm not going to spend a ton of time with link codes, only to really kind of give you an overview that lab values and vital signs are tied together by link codes. And then again, a link code can be mapped to a Snomed code. It's just a standardized code for a lab value. It's coming up more frequently now because pharmacies are doing a lot more point of care testing, more blood pressure evaluations, things that historically hadn't either been done or hadn't been reported. And so now these are things that are being added to the pharmacist eCare plan. And so it's more important to understand now that getting the right lab is vitally important. One of my pharmacists and I spent more time than we would care to really trying to make sure that the lab that we're saying we're getting is actually the right link code. So if you think about it, something as simple as diastolic blood pressure, and that's not a great example because it's pretty standard, but if you said, I want to grab blood glucose, well, what does that mean? Where'd you get it? When did you get it? What units did you report it in? So LINC has different code sets to be very, very specific about that. There is a LINC code for I grabbed capillary blood versus I grabbed venous blood for a blood glucose reading. And so, we've gone through, and systems like PioneerRx and other systems have mapped. When I say this is creatinine clearance, it's mapped to this LINC code and then consequently to a Snomed code. That allows us to report those labs and be confident that when I said I got your blood glucose, the doctor didn't assume that I got it from venous blood or some other source. So again, that keeps the safety and the ability to speak the same language all in the same bucket. So if you haven't seen LINC codes, you probably won't see a lot of them, but just know that when a place like an EHR gets a set of labs from like LabCorp or any of the other big lab facilities, all of those are still tied on the back end and linked together by a LINC code. They also have a great icon. It's a little pig. So if you haven't seen LINC, check it out. Next slide. So now we're going to start thinking about how we tie all of these things together. Knowing that there are NDCs, GCNs, GPIs, all these different codes that are either proprietary or open source. What do we do with them when we've got them? So I mentioned FHIR earlier. It's a transport setup that uses HL7. It has in it defined data formats and elements. It also has, and everybody's buzzword there, you'll hear API said by everybody. All it is an application programming interface. And with FHIR, it also gives you the ability to make some human readable components of that. And I've got on the little chart here kind of how that process all lives together. So you have a foundation. Inside that foundation, you've got your base documentation, XML or JSON. Those are just IT components. And then each of those different levels beyond that have concepts in the healthcare system. So when we really think about, say, a clinical component here in level 4, those would contain things like allergies, health conditions or problems, procedures, what I did, your care plan, your risk assessment, so kind of questionnaires going back and forth. So all of the level 4 pieces are really, those are big components within the eCare plan. So if you really think about all of this diagram, don't pay as much attention to levels 1, 2, and 3. Really think about level 4, because that's where, as pharmacists and healthcare providers, those are the kind of things that you're going to put in there. Or if you work for an EHR, those are the kind of things we're going to map from an active medication list in your pharmacy dispensing system to the medication list in FHIR format. Next slide. So when we're looking at FHIR resources, they're really just data elements with a unique identifier. So the analogy here is a website URL. So when I go to Google, I type in Google in my search bar, it's going to go to HTTPS for secure www.google.com, right? So it's giving me a unique place, an IP address to go to, and the FHIR resources and elements are going to do the same thing. So in theory, later on in interoperability, the ability to use these resources as a common language gives us the ability to say, I got my med list from pharmacy 1, a med list from pharmacy 2, plus my hospitalization med list and what my doctor thinks I'm on. And I can combine that into a single source of truth, right? I don't know how many times over the last decade I've been a pharmacist that everybody thinks they've got the perfect med list, and in reality, no one has the perfect med list. So we're going to be able to use FHIR eventually to do these types of things. So think about a med rec across infinite number of places a patient goes to get healthcare. And that is true of med lists, patient demographics, allergies, health conditions, and then even more advanced clinical outcomes. So when we're getting into the pharmacist eCare plan later, being able to share what a pharmacist did, what the outcome is, and being able to share that with literally anybody in the health system is a tool that we've never had. Next slide. Okay, so in terms of clinical concepts, we kind of went over that. This is that level 4 piece. All of these concepts, care plans, including goals and interventions, diagnoses, labs, problems, and medications, all tie into those concepts. And soon we'll be able to have structured questions and answers in that clinical concept. So let's say my pharmacy completes an eCare plan with a patient and sends it to their doctor's EHR. All of those pieces, the doctor can say, well, somebody at the EHR would have to map it, but they could say, I want to receive these things at certain times in my workflow. Because these concepts all tie together, but they're also standardized independent components, when would a doctor want to look at a medication list? Probably not at the same time that they may or may not choose to review the diagnosis list, because it probably came from them. So it allows you to use these as a single component as a document itself. It also allows you to use these components as standalone pieces. So when we think about an API or that type of setup that everybody says, oh, I've got an API and you can just create endpoints. What this does is it allows you to say, I want to subscribe to these types of endpoints and use them where it's convenient for me, as opposed to today's world where if I send an intervention to a doctor and it's 10 pages, it's probably going by facts. And the reality is, if it's longer than a couple of sentences, it's probably not going to be read. This allows us to map the concept to the need and inject it into the right place in workflow, if there's a right place. You may just consume a medication list and add it directly in. So the ability and flexibility there is really, really big. Next slide. So taking all of the structured language, the value set, FHIR is a way to get the document from one place to another. Now we come to the Pharmacist eCare plan. I highlighted here, there's a great resource that CPSN USA has built out for the eCare plan initiative. It goes through a lot of detail about what the eCare plan is and how it's structured. But generally, when you think about the eCare plan, think about it as, and referencing the JCPP here, this wheel of collect, assess, plan, implement, and monitor, right? That's your standardized, everybody's seen this, patient-centered care. So the Pharmacist eCare plan, big thing to grasp here is longitudinal. So the eCare plan, a pharmacist has a care plan for a patient that exists from the time they first see that patient until the time they never see that patient again, whether they move, leave, die, or whatever may happen. And when we share the eCare plan, it's a snapshot of that plan at that point in time. So the thing to remember is that when you send an eCare plan from a pharmacy to a payer or a provider, you're literally sending the entirety of that information. So the whole longitudinal care plan, and it's structured in a way that the receiver of that plan can say, I only want the latest information, or I want all of the information. That also means that the Pharmacist eCare plan and care plans in general were not meant to print out or fax entirety to a doctor. You could see if you had a patient with multiple health conditions, 10 or 12 drugs, and you've been seeing them for 10 years, your printed out care plan could be 40 or 50 pages. The beauty of them being structured through Snomed Codes and through FHIR-based eCare plans is that data is now structured and consumable. So the person who's writing it to consume it can say, I want all, some, none, or combinations of those throughout the eCare plan. Gives a ton of flexibility around sharing data and sharing relevant data. So again, it is structured. It has different components of the eCare plan, so health conditions, observations, patient goals, and then interventions. There are a lot more detail around those types of structures, but those are your high level, kind of, these are equating to the four main components of your SOAP note. It can be very detailed, it can be very light, but that's the general structure of it. Next page. So I mentioned before that the Pharmacist eCare plan and FHIR in general had built in natively the ability to make that care plan readable. So this is kind of what you would see in Pioneer today if you were to open up the eCare plan and ask for the human readable version. So on the side, those are the main components of an eCare plan. So you've got your demographics all the way to why I saw the patient. It's going to send over their insurance coverage, drug allergies, health conditions, goals right here in the center of the screen, as well as what that goal addresses, generally a health condition or another Snomed code, and then interventions that show which medications you're specifically making an intervention on. So the way it's structured is you have a goal, which may be to provide education about heart failure, and you would have an intervention that I actually did provide that information. Within that, it's important to know that the goal has a Snomed code that we can tie to, and the intervention also has a Snomed code that we can tie to, so that you can see on your SOAP note area where you provided a page and a half of notes. At its core, I can map that all back to a single code that says I provided education about management of heart failure. And it related to these 3 drugs that I've mapped to an NDC to a Snomed code. And it relates to this condition that I have an ICD10 that's also mapped to a Snomed code, right? So it's all coming back to same language, common structure, hierarchical descriptions of what happened, when, and why. Next slide. So this is kind of where we go from what we currently do to where we're really trying to go with interoperability. So when anybody says interoperability, health information exchanges, things like that, this is where we're going. So health information exchanges are built to be repositories to accept information about a patient, as well as be able to pull that information out for those who have access. There are a couple, functioning HIEs across the country, but the ultimate holy grail of that isn't to necessarily just have a couple of functioning HIEs across the country. The goal is to create kind of a network of these HIEs that then also share data between those HIEs under a common umbrella. The ONC is working on that, probably a few years away from being there. But there's another kind of underlying group of that with the Pharmacist eCare plan or FHIR-based transfers of information. We can bridge that gap fairly quickly. So when you think about the internet, there aren't just basic hubs of internet across the country. The beauty of it is there's millions and millions of servers across the globe that are interlinked. So you don't have to have big repositories that sit in different places. All you have to do is be able to share information across those linked networks, and you've got a nationwide health information exchange. So at its ultimate goal, the ability to send these eCare plans back and forth from pharmacist to doctor, doctor to pharmacist, and any other place creates these virtual HIE networks that can bridge that gap until we have a fully functioning network of HIEs across the country where we can share really, really robust information. And this little infographic here kind of gives you the whole set of players, from pharmacy to hospital, specialists, labs, patients even are part of that HIE. It should be a place where a patient can go and pull down their health record and consume and understand it. We are clearly not there yet. Again, just so you know, and here are some buzzwords, the types of exchanges that are possible out of a health information exchange are in the common area where they happen today, query-based. So some of you may be familiar, SureScripts has a product that hospitals can go to. A patient goes to a hospital and doesn't know what medications they're on. The hospital can query or just ask for information about that patient and pull down their med list if their pharmacy provides that information to SureScripts, which most of them do, including Pioneer. So if a patient who goes to a Pioneer pharmacy goes to the emergency room at 2 in the morning on a Wednesday, that emergency department can actually get that patient's med list without having to wait until the next day when the pharmacy's open. The next type is directed. So that would be coordinated care. Think of that as being my example earlier with my rotator cuff going from my primary care doctor to my specialist, and that PCP sending all of my information ahead of me to the specialist electronically in real time so that I don't have to check out my x-rays and carry them up the stairs. Those two things happen reasonably often. Query-based in the ER is probably the most common. Directed is happening in places where big health systems have the same EHR and they can transfer that information back and forth. Not as frequent, but it does happen. And the next one of those is where our current ONC and administrators are really trying to push. In fact, there are a couple of laws up in the air right now directed around this exactly. Being able to have the capability of a patient to request their information at any time from any provider and get all of it. Today, this does not happen. I also put in a buzzword here. You may hear a lot of people talk about blockchain technology to drive the information back behind the health information exchanges. At a high level, just think of blockchain as it's a very, very secure technology that allows different people to read from it, write from it if they have the keys. If you're really interested, you can look into it more, but you will hear people mention blockchain in combination with health information exchanges. Next slide. I kind of went over this a little bit on the last slide, but one of the things that we talked about, this has been a fairly nebulous presentation of all this keywords and buzzwords and everything else. So I wanted to give you a quick kind of overview of where interoperability is currently happening. Where it currently works today, electronic prescriptions. It doesn't matter if you're in a hospital, in a pharmacy, sending and receiving e-scripts is maybe the only place where true interoperability happens millions of times a day. And you only really think about it when you have your e-scripts go down and it takes longer for you to get prescriptions. There are a couple of areas where it's kind of working. The Pharmacist eCare plan. Today there are, I believe, 11 pharmacy software vendors, PioneerRx included, that are sending eCare plans from a pharmacy to CPSN USA that is facilitating those to payers, third parties, somebody who's interested in outcomes for patients. That is also true in the enhanced MTM world, where those enhanced MTMs are being sent to CMS for evaluation. Immunization registries, being able to support, I provided a flu vaccine and send that into my state registry. That happens today in pharmacies. So PioneerRx can report immunizations to registries and receive information from registries where bidirectional information is available. Labs can be sent from LabCorp to an EHR. The reason I say it's almost working is in a lot of cases, these are one way, sending from one place to another, but no ability to reciprocate. Or they're limited in their scope of healthcare providers. So today, the Pharmacist eCare plan, we can send it, we could receive one, but we don't yet send those to or from physicians, nurse practitioners, occupational therapists, etc. Immunization registries, similar. They're usually one direction, so I can send from a pharmacy to a registry. Some places they are bidirectional, but they're still not really crossing state lines. So if I got a vaccine when I was on vacation in Florida, it might be reported to Florida, but it wouldn't necessarily also be reported to Texas where I live. And labs for the same boat. They're going from the lab to the EHR and really stopping there. There are some other limited capacity where you can get that information, but it's not really fluid yet. And then unfortunately, where it's not working yet is literally everywhere else in the healthcare system. We're all working toward it, but it's really, one of the things I heard a lot in the last PQA meeting was, hey, cool, we can just create a national identifier and link all this information. It can be done, but we're looking at a 5-10 year march to get all of things organized, structured, and mapped. So there's a march. It is happening. and we're headed in that direction. In the last couple of things, I mentioned that there are a couple of rules and regulations in flight around really enforcing interoperability. So one of them you may hear some about is TEFCA, and the other is information blocking. Not going to spend a lot of time in them because we're still waiting on the final ruling, but they are there, and basically it's a way to force healthcare systems to be more transparent and interoperable, really geared around patient or consumer transparency. But when you require a health system to provide detailed, transparent records to a patient, that kind of filters down everywhere. So TEFCA and information blocking will be big in the coming months. Next slide. Here's just a couple of resources. These are websites I check daily. So if you want to know more, dig in a little bit deeper. If you just pick one, I would pick the Pharmacist eCare Plan Initiative. And if you're really nerdy, the Pharmacy HIT group is fabulous. I can't recommend them enough. But beyond that, those are the super, super high level interoperability. We are pretty much out of time, but if there are any questions, I will happily take them.
Thank you very much, Josh. We are slightly out of time. I want to respect people jumping on to the next couple phone calls. So I just want to thank you again for this presentation. It is recorded. It can be available online for people that want to listen to it again or share with their colleagues. As a reminder, we have our PQA annual meeting. Registration is open. It's going to be this May 13th through 15th in Baltimore, Maryland, and we hope to see everyone there. And again, we'll see everybody or talk to everybody during our next quality forum on March 12th. Josh, thank you again so much, and I hope everybody has a wonderful day.
Great. Thank you.